very much. Oh. Thank you. So it's my first time here at HIV Scotland, so I'm really pleased to be invited here so that we could share some of the results from the Positive Voices survey that was conducted in 2017 in England and Wales. I'm afraid not in Scotland this time, hopefully next time. Having done this, having been invited to do this talk, actually gave us an opportunity to interrogate the data with regards to loneliness and isolation in a little bit more detail than we'd done before, and came up with, I think, some really interesting results, some of which sort of reinforce some of the things that have already been brought up today, and some things which may sort of flip things on their head a bit. And a spoiler alert now, but aging isn't it. So bear with me if I've gone off the brief a little bit with the aging theme, but I hope you'll find this data really interesting. So as I was sort of introduced, thank you. I work at Public Health England. I work in the National HIV Surveillance Team. And so we collect case reports from people with HIV. We collect information about people in care, try to understand the epidemiology. And since 2012, I've also been the coordinator of the Positive Voices survey, which is a national HIV patient survey. And it was piloted in 2014, and we ran the first national round in 2017. So this is the first national data that we have. So what's really unique about Positive Voices is that it's nationally representative in England and Wales. I have to say that one, I'm sorry. And the way that we did that is we used our national surveillance systems as a sampling frame to invite a random sample of people attending their HIV clinics to take part. Okay, so it wasn't perhaps recruited through voluntary organizations or online only or something. So in this way, we tried to get a really good cross-section of respondents and recruited them where they are attending, which is in the HIV clinic. So in order to get, again, as wide a representative sample as possible, we asked the clinics to recruit the patients that we sampled, ideally face-to-face, but if they didn't attend during this period, and as we know, stable patients are seen maybe less frequently, they could also be invited via post or by email if they'd given consent to that contact. We also gave multiple survey mode completion options, so we gave everybody a paper option, but they also had the choice to respond online. Most people responded on paper, but a really important group of about 600 people chose to go online to complete. And really importantly, we gave people an unconditional incentive, a £5 high street voucher, which they could keep whether or not they took part in the survey to try to boost our response rates. So in total, we invited there's around 180 HIV treatment centers in England and Wales. We invited them all. 73 came back and said, yes, they'd like to take part in the survey. And the map shows the distribution of that, so we had quite good distribution geographically. And in total, we had just over 4,400 responses. So that makes it the biggest ever survey of people with HIV in the UK. And we had a good response rate, and that sample actually represents 1 in 20 people with HIV in England and Wales who took part in the survey. And this graph is really just to reassure you what I've already told you, which is that our representative sample was real. So in the pink line there, we have the demographics, breakdown of the Positive Voices survey respondents, and next to that in the blue are all people accessing services in that same time period from our surveillance systems. And what we can see there is that we have a very closely representative sample, slightly overrepresented older white gay men, but we have then weighted the data to try to improve that sort of generalizability. Okay, so on to the results for sort of the loneliness and isolation. So I have to start by saying we didn't, and this may come up later if we're doing a sort of workshop later on measurement. So there was no specific measurement tool that we used to sort of quantify loneliness and isolation exactly in the last survey. That may change for the next survey. But what we did do was we did a needs assessment within the survey. We asked about different types of needs: HIV-related services, health-related services, and social and welfare services. And within that latter category, one of the things we asked is did you need help dealing with loneliness and isolation in the past year? Okay, so then we defined whether or not people needed that help in the following way. So of the people who answered the question, indicated an answer, we had 4 different response categories that people could give. Sort of from left to right, you can see people said if they needed this and they received this help, they needed it but they could not get it, they needed it but they did not try to get it, or they did not need this. So need was defined as those first 3 groups out of everybody who responded. So that was sort of how we gave a percentage need. And then similarly, we were able to measure unmet need of that need. And by doing that, we looked at, sorry about that. So actually, that little thing should only be those first 3 categories. So that was our denominator, as it were, the people of those who had a need, who did not receive the help that they needed in the past year. So I'll present some of the key data around this, but I'm going to be focusing mainly around need for help with loneliness and isolation. Okay, so this is a big graph, and so I'm only doing this, don't need to read this all, just to demonstrate where loneliness and isolation sits in this whole sort of array of different services that people could need or need help with in the past year. So unsurprisingly, people, the need for HIV-related services is quite universal and was very high. And you can see that on the bars on the top group on the left-hand side. And then health-related services mainly need around psychologists or counselors, stress management, weight management, advice regarding sex life. And on the bottom tier there, looking at social and welfare services, well, the greatest need was for housing support at 22%. The second greatest need was for help dealing with loneliness and isolation with 20%. And 1 in 5 people said they needed that help in the past year. But when we're looking at unmet need, what you can see here is that out of all the services we asked for, 29 different services, loneliness and isolation was the one with the greatest level of unmet need. So 75%, 3/4 of people who needed that help did not get it in the past year. So we looked at that in a little bit more detail, and I'll sort of be presenting some of the results of our interrogation. I think as well I should really point out that this data I'm about to present is possibly only the tip of the iceberg when we're talking about loneliness and isolation among people with HIV, because they'd have to say they needed help with something, which means perhaps they'd have to recognize that they had an issue or had this need in the first place. Which may not be everybody. Okay, so we'll break down this met and unmet need. So as I said, of that 20% of people who said they needed help, 3/4 of that need was unmet. We were able to look at some reviews that had been done previously by AIDS UK, and they estimate that compared to that 20% need, in the general public, the estimates are around 6 to 13%. So this is indicating that there may be an excess burden of loneliness and isolation in the HIV population compared to the general public. Then we look at more detail about those sort of other categories of how people access that help. So as we already presented, about 1/4 of people did actually receive help with loneliness and isolation. A further 21% said they needed this, but they did not try to get it. And over half of people said that they needed it, but they could not get it, indicating that perhaps they did try, they did seek in some way, shape, or form to try and get help with this, but they weren't able to find this. And so I think it's important as well to note here what would have really benefited, I think, in more depth in this data, and I have a little bit of qualitative data there, but is more analysis about perhaps how people understand loneliness and isolation, how people recognize that, and whether or not people actually know that there is help and support out there. So it could be that they actually, in doing the survey and getting that service, put that on the list, and for the first time ever looking at that and say, yeah, I do need help with that, but I didn't even know that was something I could get help with. I didn't know there was a service that might support that. So that's sort of interplaying in there as well. Okay, so we looked at the need for help with loneliness and isolation by different demographic factors. And I think the first one here is perhaps the most striking. And this is looking at the percentage of people by different age groups who said they needed help with loneliness and isolation. And what this shows here is actually the highest levels of need among the youngest people and the lowest levels among the oldest people, which is not what we see in the general public. It's actually quite the opposite. We also looked at different gender groups, so men, women, and trans and non-binary populations, slightly higher rates again among women and trans populations, just slightly. And then when we looked at need by ethnicity, the slightly higher rates of people of Black, African, and other minority ethnicities, other white Europeans, so non-UK born, and this is reflected here as well. But before we draw any massive conclusions for this, I should also note that when we looked at this in a statistical way, none of the differences that we're seeing here were statistically significant. So what this tells us is in the HIV population from this data, age isn't really a factor. It's universal across age, gender, ethnicity, and whether you are born here or a migrant. This is what this data is showing us. And we have a very similar sort of pattern we see when it comes to unmet need. I should note that in some of these groups, the numbers are quite small, so we get a little bit of sort of instability in the numbers. And you may see here that the greatest unmet need among people who are over 65, but this is probably representing about 10 or 20 people. And again, some variation among gender, and different ethnicities and countries of birth. But again, none of these differences were statistically significant again. So perhaps again indicating that whether or not that need has been met is not necessarily due to these types of demographics and disparities in inequalities in that area. So what factors were associated with needing help? So the first one is having a main partner. It's probably very unsurprising. So whether or not somebody had a main partner, a boyfriend or girlfriend, husband or wife, or a spouse, 31% of people who said they didn't have that needed help compared to 12 who did have that. Employment status, and this was mentioned before as well, those who were unemployed were more likely to say they needed this help. And I think another bit that I didn't put up there is in the survey, we sort of calculated a group called economically inactive, but that includes retired students, people on long-term and short-term disability, and those individuals as well had greater need for loneliness, help dealing with loneliness and isolation. Health status, and Fiona mentioned this very much, reporting that your health was bad or very bad, half of people said that they needed this help compared to people who said they were in good or very good health. And then we also had a measure, I would say this measure was mainly focusing on stigma in healthcare settings, but those who did report being worried about experiencing stigma related to their HIV were more likely to say they needed help with loneliness and isolation compared to those who didn't. But the most important factors, so I'm going to present two now, that came out as the strongest factors associated with loneliness and isolation. And the first one of these, and the strongest one, was really mental health issues. So having symptoms of depression or anxiety. And we can see here a very strong linear relationship with that. So on the left-hand side are people who say they had no symptoms of anxiety and depression, and then those sort of increased to slight, moderate, severe, and extreme. And so people who said they didn't have any issues with depression and anxiety, only 7% of those said that they had needed help with loneliness and isolation, rising to 76, 3/4 of people who said they were extremely depressed had issues with loneliness and isolation. So that link between mental health and loneliness is very, very strong. And we also talked a little bit before about, I think, comorbidities and function and ability to move around. And so likewise here, when we asked about symptoms of pain and discomfort, we again saw quite a strong linear relationship where people with no symptoms had the least amount of issues with loneliness and isolation, and over half of people who said they were in extreme pain and discomfort. And I think it's important as well to sort of then kind of triangulate that with some of the other data that we have around function and well-being from this survey, to perhaps explain, which help us explain why there may be this additional burden in people with HIV. So we asked within the questionnaire a 5-item sort of quality of life questionnaire. If you were here perhaps seeing Jane's talk last month, Jane Anderson's talk, this is one of the sort of most commonly used tools in Europe. It's called the EQ5D or the Euroqual, and it looks at different domains of quality of life. So in the red bars is the Positive Voices survey participants, and in the blue bars is the English general public, so that's sort of some reference data. And what we can see here is that actually among all the domains, people with HIV have a slightly greater need, but that is very much so around depression and anxiety, where we saw twice the amount of people reporting issues with depression and anxiety than the general population. So you can see there's a clustering of risk, a compounding perhaps of risk around the area, mental health and loneliness. And I think it's also worth noting that a couple of areas that we didn't see associated, which were surprising to me at least, was where people were living, if they were urban or rural residents. 3/4 of the respondents lived in urban areas. But actually, we didn't really see that association that you might have expected. We looked about disclosure of HIV status, and now this is people who'd ever disclosed or shared their status with anybody else compared to people who had never disclosed. We didn't really see an association there. And I think finally, reassuringly, we didn't see any sort of link between whether or not people were virally suppressed or not. And I think that's very much thanks to the effectiveness of HIV treatment and our fantastic NHS that the treatment is keeping people HIV under control, but maybe not all the rest of the issues. And so I just wanted to present, I think, we had some area, some space for people to share, write down some of their thoughts and feelings around all the social welfare needs that they might have had and why they weren't able to get those. And so I thought it's always most important, of course, to hear the lived experience and to understand the context around some of those. So some of the reasons that people say they didn't get help with them, one, nobody seems to deal with loneliness, or nobody has ever asked me if I'm loneliness or isolated, which I am. All my friends are in London, but I'm stuck here in North Somerset. Another one sort of thing that came up was around maybe comorbidities or other chronic conditions. This one woman said, I was diagnosed with autism Asperger's last year, and there's no help or support available for it. I don't have or make friends, maybe finding it more difficult to do that, and I suffer from depression and anxiety, and I get panic attacks. So perhaps for them, going out and finding friends and making social connections is more difficult. And likewise, this second quote very much links in with that pain and discomfort and mobility. I live on my own with these chronic conditions, HIV and debilitating backache. I desperately need help, but I don't know where to get it, for example, social groups. And of course, and again, Fiona mentioned this before, and I think this can't be overstated, although we don't go into it in a great deal here, whether people can afford to get around to socialize and things like that. So somebody said, I'm just simply unable to afford transport to get around to have a social life. And then I think stigma, of course, is a massive issue here, and perhaps some shame around HIV and how you negotiate that. So the top one, I have been widowed for 13 years and I stayed single. Life is lonely like this, but I worry about meeting someone and then explaining my situation, presumably the HIV. I don't know how they'll react. So in that way, perhaps the self-imposed isolation due to shame around HIV. And likewise, still very conscious and almost ashamed of the fact that I'm HIV positive. While society has come a long way, there's a lot of judgment towards people living with this disease, a lonely illness to have. And then finally, I think something that many of us can actually just simply relate to: never ask for help because I'm too embarrassed. So perhaps with clinicians or people who are seeing people on a daily basis, many people won't come forward and actively perhaps volunteer information about being lonely or isolated until you ask them actively. Okay, so I think the last bit of data that I just wanted to present here is around looking at variation. So we had 73 HIV clinics, and this is some work that we will be continuing and building on, but looking at why there is such variation in the need between different clinics, ranging from 6% of people who said they need this to 37%. And something that we will be doing more in depth looking at is where there are looking at unmet need across these clinics and where there are examples of best practice where this need has been met well, and that's going to form some further work that we're doing. So I just wanted to follow with a couple final thoughts, but of course, so what we can see from this data is perhaps loneliness isn't in HIV population an age-related issue, but the AIDS UK and AIDS Scotland groups are the ones who've done the most amount of work around this topic. So I think there's quite a lot of lessons to be learned from the work that they've done, from evidence reviews that apply to HIV. And I think one of the most striking quotes that came out, and I think is increasingly true in this day and age, at the bottom here, is that HIV affects the mind more than the body. I used to be strong, but now I get so lonely. So again, reflecting this change that we've seen, this evolution, and people living well with HIV, so they're healthy and the HIV is under control, but what about all the rest of the factors that are associated with well-being and living long, healthy lives with HIV? So finally, and these are just my thoughts, maybe not PhD endorsed thoughts, but these are mine. So again, I said the first thing that can be done, I think, is we can use this data to find and identify examples of best practice where loneliness and isolation need is met, so that we can perhaps adapt, replicate, and scale up in other clinics. Perhaps recognizing now that the sort of typical patterns of loneliness and isolation may not apply with people with HIV, and in some cases perhaps it's less of a physical isolation that we're seeing and perhaps more psychological isolation. And then, as I said before, so actively seeking out and asking patients about their need around this issue, and so identifying risk perhaps at routine appointments. Some of these things I've already identified around mental health, pain and comorbidities, living alone, being unemployed, mobility issues. Those are things that, once identified at the clinic setting, can then lead to a further discussion around loneliness and isolation and whether people need help. And so, of course, from the HIV clinic perspective and also from support group perspective, must actually, establish signposting, referrals if possible. HIV peer and supporting groups haven't talked about much, but are absolutely priceless with regards to getting social contact for people with HIV. Occupational help for getting people back into employment if they need to, if they want to. And then links to also general well-being and social groups. So maybe an HIV-specific group isn't for everybody, but there are general well-being groups out there that you can make links with. And of course, last but absolutely not least, is just tackle the HIV stigma and spread the message of you equals you. When we collected this data, we joined up with Positively UK, which is a HIV patient organization, and National AIDS Trust, to do some workshops with people who'd actually filled in the survey, to ask them what they thought was the most important data, what was the most striking, what did they want us to focus on. There's so much data in the survey. And one thing that came out very, very clearly was the need to tackle HIV stigma, and very, very much related to that was around the message around you equals you and the science behind that, and ensuring that was widely known and spread among people with HIV to deal with internalized stigma, as well a need for general public awareness, but amongst the group of people with HIV, because it changes everything about how people explain their HIV diagnosis to friends and family, the decisions around disclosing to partners, around family planning. It absolutely is a game changer with regards to stigma But we have some other data from the survey that shows actually the penetration of that message, while it may be hitting a lot of the sort of expert patients and activist patients, is not reaching everybody. And I even have been giving talks in some rural areas, Norfolk, where a clinician didn't believe U equals U, an HIV clinician, so he wasn't telling his patients. And so those patients were not hearing that message. That was this year. So I think still a lot of work needs to be done with U equals U, and I will be a proponent and activist on that for sure everywhere I go to talk. But I'll just end by saying thank you, of course, to all the survey participants and all the staff at the clinics. And thank you very much for having me.